part of the session. It gives me great pleasure to introduce Dr. Colonel R. Rangarao, who is an eminent oncologist. He served in the medical fraternity and armed forces for approximately 30 years. Currently, Dr. Rangarao is at Ras Hospital, Delhi, NCR. He has been associated with several established hospitals and institutes and is an award winner of distinction and has conducted several clinical trials over the years. Now I hand over the reins to our program director, Dr. Amish. Over to you, sir.
Thank you, Kashish, and it really gives me a great pleasure and it's an honor to invite Dr. Rangarao sir for live interview. Now, this is something which we started last time. Last time there was live interview with Dr. Sri Gupta, and this time we have the honor of having Dr. Rangarao sir. Thank you for joining us, sir. All of you who are present here, apart from what she has told about Rangarao sir, I think two important things which I have learned from sir. One, always be on time, no matter how busy you are. Dr. Rangarao sir, irrespective of whatever is the meeting, he is always on time. And second thing is always think about your team in progressive life. I think this is also something which sir has set an example again and again to show that you have to carry your entire team with you when you move up. Thank you, sir. With that, let us start today. And my first question to you is about the evidence-based medicine. So I'll give you an example. Yesterday, there was a 42-year-old triple-negative breast cancer into my OP, operated PT3N1M0. But she was operated in April 20 when lockdown was there, and she didn't come for any further treatment. After 4 months, she comes and she says, "Doctor, I have heard I have a very bad type of breast cancer, and I want to take chemotherapy. Would you give me?" Already 3 months have passed. 4th month, do we give chemotherapy? We not give chemotherapy dilemma. And I'm sure, sir, you must have come across such dilemmas in last 50 years of your practice. So my question to you is, how often do we practice or do we not practice evidence-based medicine in a day-to-day clinic? Over to you, sir.
Yeah, first of all, thank you, Amish, for inviting me over here. And also, I must congratulate for this concept of practice changing papers because that's how we have this stepping stone. They're all stepping stones of clinical practice. Now, I have certain very strong views about the evidence-based medicine. While it is helping us all in propagating the science further and further and treating our patients better for the benefit, we also have certain hurdles in that, and there are certain handicaps. Now, the clinical practice is not purely evidence-based medicine. In clinical practice, we take a lot of clues and suggestions from the evidence-based medicine. Add to that your experience, add to that others' experience, and then add to that science and logic from other things, and then practice. And you practicing the benefit of the patient. You are not an extension of the clinical trial that has been conducted based on which you are giving treatment to the patient. So that's my strong view. So in this patient, coming to the point, I would err on, even if I have erred, I would err the safer side in giving adjuvant therapy. I'm glad she did not have a metastasis. For all good reasons, she could still be having the micrometastasis. So I would not let her have a metastasis, because once the metastasis happens, I think it will be very bad seen. So I would give rather than not. And also I would like to add here that around us, we always cross the Lakshman Rekha. We make our own Lakshman Rekha based on evidence-based medicine. And that Lakshman Rekha is defined by you when you're practicing, how you much the gap you want to create and how very you want to cross it. So I think that answers your question. And next one, Amish, over to you.
Yes, sir. Sir, do you can you give one example like the way I have asked? In that evidence-based medicine is something we couldn't practice in your out of your experience. The patient did well.
Yeah, right. I'll just quote one of the recent, one of the child. She's about 12 years, 13 years old, very influential, very good family. She had multicentric osteosarcoma, and she had a metastatic disease to the day one. She flew all the way to one of the famous centers in New York, and there she had the whole treatment, and she had all possible lines dictated by evidence-based medicine. And then she was told that she's not going to have any more treatment because she's not going to respond. So they had returned from there, and then based on certain molecular inputs in the patient, so one of the local molecular oncologists had suggested molecular with some kind of treatment, and then that treatment. This is not based on any evidence-based. This is purely based on the science which is given by the molecular. In fact, mind you, even I was very hesitant to give anything to the child because she was having such morbid bilateral fluid occlusion on chest tube. Anyone would hesitate. And then when she had the molecular treatment based on that, she had an excellent response. PET scan actually showed a very good response. So with a little over enthusiastic treatment, what happened was she ended up into viral hepatitis, and then she had went to cytopenia. She recovered from all that, and then again once she recovered, there was a pressure from the father because he saw it. And then he said, like that, we can keep crossing the things with Lakshman Rekhas a number of times, and there will be many examples, I'm sure, each and every oncologist experience. I'm sure there will be many like this.
Thank you, sir. It's a very, very famous example. 1/3 of Indians may be suffering from diabetes, and majority of the new drugs have exclusion criteria of uncontrolled diabetes. Now, how do we? This is one of on drug. Let's move to the next question, sir. I want to ask you, according to you, in last 20 years or 30 years of your practice, if I have to ask you 3 practice-changing papers which have revolutionized the treatment of oncology. Like if somebody asks me, like I love example, I would say the approval of tamoxifen breast cancer, the drug which failed, a drug for infertility treatment, and it got approved in breast cancer. It gave 2 concepts. One concept, all forms of breast cancer, tamoxifen was useful in the treatment and prevention, and the most important point was it taught us that longer can be better.
Right.
So similarly, sir, if you have named 3 practice-changing papers, which one would you name them?
Yeah, thank you for that lovely question. So, I just wanted up 2 very practice change. They changed the whole practice from the way any actually many, but since you said 3, I have chosen 2 of them which have changed the whole practice. So one of them is in the patients of the lymphoma. And in 2002, the first paper was published by the Vora and then that was a Gale trial, Italian group, which they added the rituximab to the CHOP. And just to say about CHOP for those young people, while you were reading about the CHOP in the review, this has been almost about 30-year-old regime, maybe 35 years old regime. And this CHOP has been given a tough competition by at least half a dozen, maybe a dozen, mind-boggling abbreviations of chemotherapy. None of them withstood the competition. CHOP was always the victor. And then they chose to add a rituximab, which is anti-AD20 monoclonal antibody, for the first time in clinical practice at that time. And then they added to the CHOP combination and they gave it, and they found extremely rewarding results in terms of response rate, the PFS, overall survival, literally started curing. And this GAIA trial, the first one was tried only in the elderly people because the incidence in the people above 60 years was there. So there was a debate for a couple of years. We don't have evidence used in the young people and so on. Let me tell you, at that time, everyone started using every patient. Right? And then I'm sure we've seen people are around here. That then came the main trial, then came the trial. They established almost every B-cell lymphoma in any kind of malignancy, rituximab has a role. That one important practice-changing thing. The other thing is the ovarian tumor, the ovarian cancer. We've been using paclitaxel and the carboplatin as a gold standard. Anyone you talk to them, the gold standard world all over. And then let's just see how that trial has come in and how that has changed the whole practice. I still remember when I joined Cancer Institute in Chennai, one of my first patients was ovarian cancer. She was a very nice, charming South Indian lady with a stage 3 ovarian cancer, inoperable. And then we wanted to give chemotherapy. The only chemotherapy we had was the cyclophosphamide transplant. We gave 3 cycles, excellent response, underwent the surgery, and then she had some more chemotherapy. And then no time, 1.5 years, and he relapsed. Then we didn't have any salvage. Then that's the time the Taxol came as a salvage that's being given, and then slowly it was promoted to the Taxol and cisplatin as one of the standard. It emerged. Taxol is being given 135 milligram per meter square as a 24-hour infusion along with cisplatin. So it was effective. It prolonged the survival by at least 1 year from the previous cisplatin regime. It found to be toxic. Then came the search for a better alternative, which would be less toxic. And I think this trial, the AOG trial, which is the German trial, they had the paclitaxel and carboplatin at the standard doses that we use today, but cis, patly, and cis, and then they put beyond both of that. So now inferiority trial. They've proven a 3-year infusion. So this came at almost 20 years, 18, 20 years back, and still remains as a good standard. I think these 2 trials have changed the whole practice and set the practice, and they're now competed for this. So they are golden trials. I would call them golden trials. We have set the example. Nothing could shake them so far. And we can add weekly paclitaxel game, any other thing can challenge. They come and go. I mean, this gold standard has remained all the time.
Thank you so much, sir. Today, those past BA medical oncology would use palicarbo without having the experience of using paclitaxel 24 as infusion, like you have seen even pre-paclitaxel era. And I think this is wonderful and amazing 2 examples what have been. Kashish, do we have time for one more question?
Sure.
Great. So, while you and I were discussing about this concept, one of the phase 2 trial experience which you were sharing, I think everybody would really like to hear about that, sir.
Okay, so the evidence-based medicine, when you ask a student, when you ask the youngsters, if you say, so there's no phase 3 data, how can you use it, right? So then, I just want to quote certain things. Now we're talking about oligometastatic disease. You talk to any youngster today, any person in oncology, oligometastatic is an established concept. And then now we have oligoprogression, oligoresidue, and you have many adjectives about oligometastatic. We understand that this is a distinct biological entity, and then we can have a different, kind of thing. So let me just enumerate what really happened there. There have been many small studies and retrospective analysis. What happens, many people in their own way, they treated these small metastatic diseases with number of metastases with local treatment, and they recorded the survival, and then retrospective analysis came in. They did better as compared to the counterparts which are not random. That are not a study, just an observation study. The numbers kept on increasing, and then there was a phase 2 and several single arm studies, very small, 10, 20, 30 like this, and they also established. And based on this, what have we put that come in this, the concept was definitely understood clearly by almost everyone that oligometastatic disease should be treated differently. So then in 2006, a phase 2 study was published, and this had how many patients? 49 patients, and out of that 1 patient progressed and 48 patients were analyzed. And then this was done in 3 centers in UK, in Germany, and in Canada. US and Germany and Canada. And then they did a fantastic thing. I mean, it just showed that the survival, the DF has been from 4 months to 14 months. And then the overall survival improved, and then everything else improved. The number of new patients coming up. So they continued systemic treatment, whatever it was. And then this was done in the lung the first time, and proven. And then that led to the hypothesis. We are talking of oligometastatic disease. That's our phase 2. After that, there's another study which is come and published recently, which is the SABR study, which did in multiple cancers. Same. How many number of patients? 99. Phase 2 studies. Today we are talking lecture, it's a symposium. So let's give lesson, friends. Phase 3 is not all the time the gold standard. Based on phase 2, which is extremely good, we can actually change our practices. So we can change practices based on many things, including phase 2. But to prove the hypothesis, take science forward, I think phase 3 data is coming up. I think it is expected to come in the next couple of years.
This is excellent. I mean, to imagine how many patients would have been cured based on the simple observation is amazing. Thank you so much, sir, for taking out your time. I think it is really a learning experience for us. Thank you, sir. And Kashish, over to you for the program.
Thank you, Amish, for giving me